Good morning, and thank you for allowing us to present our data today. I have no conflicts of interest or financial ties to disclose. Obesity is an independent risk factor for kidney disease and progression towards end-stage renal disease. Obesity alters the renal hemodynamics and biochemical pathways that results in glomerular hyperfiltration, which has been linked to the progression and development of kidney disease. Studies have shown that hyperfiltration normalizes after bariatric surgery. However, most of these studies are small study groups and with assessment of short-term outcomes. We examined the renal function in patients who underwent gastric bypass with long-term follow-up. We hypothesized that the hyperfiltration resolves after bypass with long-term renal function stability. This is a retrospective review of a prospectively well-maintained database that includes demographic, anthropomorphic, and comorbidity data. This is a 10-year study period from 2002 to 2012, and over 2,000 gastric bypasses were performed. We excluded all patients who did not have at least a 2-year follow-up or who did not have a preoperative or at least one postoperative serum creatinine or weight measured. So our final study group number was just over 1,000 patients. So we stratified the study population into subgroups for comparison. We looked at age group and divided them to reflect the age-related decrease in renal function. We broke down obesity classification based on the severity of their obesity. We also looked at their preoperative renal function. A creatinine clearance of more than 90 would signify an absence or stage 1 kidney disease, and a creatinine clearance of 60 to 89 is stage 2, and a preoperative creatinine clearance of less than 60 would be stage 3 or higher chronic kidney disease. And we also wanted to look at the weight loss success with a percentage estimated weight loss of 50% or higher. So when we look at renal function, we know that GFR of greater than 90, we assume that they have a normal renal function. But what we don't realize is that when the creatinine clearance is 120 to 175 or higher, it would signify glomerular hyperfiltration, which is an early development of kidney disease. So it's really hard to do a direct measurement of GFR in the clinical practice, so we used the Cockcroft-Gault equation. However, in the obese patient, this becomes less accurate. So therefore, we corrected it using the adjusted body weight, which has been shown to consistently approximate the creatinine clearance. For our data analysis, we used a linear mixed effects models used to compare patient subgroups. Separate models were then fitted to data from female and male subjects, and the estimated change from baseline, renal function overall, and each time point were characterized as geometric mean ratios. In our population, 87.5% were women. We only had 150 men in this study group. Looking at the initial consultation, we see that the patient were between the ages of 40 to 59, class 3 obesity, and with a creatinine clearance of greater than 90. When we compare men and women, we see that the men always presented older and higher BMIs. We did not see a significant difference in terms of their preoperative renal function. Now, in this graph, this is only looking at women, comparing their renal function by the different age categories. You see that the age less than 40 is noted by the black line, had a hyperfiltration rate. But when you look at each age category over time, we see that there is a significant decrease in their GFR and serum creatinine. When we look at men by age category, again, the younger patients had a higher filtration rate, but we only saw significant difference in the age between 40 to 59 with an increase in GFR and decrease in serum creatinine. Now, when we compare them by their BMI categories, we see that in all categories that we see that the GFR and serum creatinine decreases over time. And again, in men, however, we did not see that their GFR changed over time, but we did see in class 3 and class 4 obesity that their serum creatinine did decrease. Now, looking at the preoperative renal function in women, looking at the creatinine clearance of greater than 90, the mean GFR was about 129, hyperfiltration. We saw that the GFR decreased and their serum creatinine decreased. When we looked at stage 2 kidney disease at pre-op, their GFR remained stable over time and their serum creatinine decreased. And if they had stage 3 or higher, we actually see that their GFR improves going from stage 3 to creatinine clearance of 60 to 90 with a significant decrease in their serum creatinine. Looking at men by preoperative renal function, we see that the patients with creatinine clearance of greater than 90, their GFR did not change. Their serum creatinine also did not significantly change. With stage 2, we do see an increase in their GFR and decrease in their serum creatinine. In the stage 3, we only had one patient, so we didn't do an analysis, but you can observe that his GFR did improve with a decrease in his serum creatinine after his surgery. Now, we're looking at patients who had successful weight loss, and you could actually see over time there's a trend with normalization of their GFR. And over time with the patients who had unsuccessful weight loss, their GFR started to increase over time. We did see that both groups had a decrease in serum creatinine in long term. We also see this difference in the male patients. The patients with this weight loss success had a GFR in the range of normal filtration rate, whereas the patients with unsuccessful weight loss had elevated GFR in long term. So in our study, we show that there's an improvement in renal function after gastric bypass. We saw that there's normalization of glomerular hyperfiltration. We also see in a subset of patients with preoperative kidney dysfunction that there's a regression. And we also show that there's long-term stabilization of improved renal function. Our limitations for this study is that it is a retrospective review. GFR is an estimation, and there tends to be some variability in their GFR calculation in the obese and super obese patients. Thank you.